Good evening, everyone, and as well as good morning for those presenter and participants from Europe. Today we have an interesting session in the abstract session, which is under Miscellaneous. So I'm moderating as well as Dr. Fabio Posas. I think later he will probably come in. We have panelists Dr. Alan Fong from Malaysia, Sun Jun Hong, Windows Zhang. I hope I got the pronunciation right. So without further delay, we would go to the first presenter, the title being 5-oxymethylurecyl simulate new angiogenesis in post-infarction cardiosclerosis model in rabbits, that will be presented by Dr. Bogdan Olinik. I hope I got that right. Dr. Bogdan, please.
The purpose of our investigation has been a study of the effectiveness of the pyrimidine against, that is 5-oxymethylurecyl, as a neogenesis stimulant by determinant of the density of the vascular network and structural changes of the left ventricle in the post-infarction cardiosclerosis model in rabbits. The 5-oxymethylurecyl, which is a pyrimidine derivative, is a minor based on the can be found in significant amounts in the RNA and DNA and support the significant role in the function and the metabolism of these polymers. The medication has been anabolic, antioxidant, and immunomodulatory effect. Experimental acute myocardial infarction has been in 53 chinchilla male rabbits with an average weight of 2.2 kilograms. During the experiment, the principle of the European Convention on the Protection of Vulnerable Animals was observed, which they used the experimental and other scientific purpose. Significant treatment on the carried out on the operation room based in the vivarium of Bashkir State Medical University. Anesthetic support was provided by means of ketamine solution intramuscular administration. In the case, autonomous breathing was maintained in the rabbits, which included the use of mechanical ventilation. Longitudinal sternotomy was conducted to test animal, after which the pericardium was incised and the heart was exposed. Proline 8.0 suture was applied to the anterior descending artery of the body of proximal and middle third of the left arterial appendage, lower boundary region. To prove the formation of myocardial infarction, that a clean solution was bolus administered in the marginal vein of the ear, which the fluorescence properties on the ultraviolet beams when the heart illumination in the Woods lamp in the dark room. Right yellow-green fluorescence on the heart with the perfusion defect and the blood supply region on the anterior descending artery is determined. As the infarction confirmed by change in the ST segment according to the electrocardiography in the start lead second. Subsequently, macroscopic slide revealed in the post-infarction cardiosclerosis site on the left ventricle anterior wall as the white side. 4 weeks after surgery, all animals were divided into 2 groups at random. The experimental groups comprised of 27 animals obtained 5-oxymethylurecyl medication as peritoral administration at a dose 55 milligram per kilograms live weight of the 3 times a day within 14 days, and the control group comprised of 26 rabbits as well. His experiment animals are the one overdose were eliminated 2 weeks after the drug ended. Our first stage was to conduct a morphological study with the quantitative assessment of revascularization. Following euthanasia, the rabbit hearts below the ligation was increased edgeways using the special device for a 3-segment uniform the thickness, that the apical, made cavity, and basal. Histological section was stained by this hematoxylin, iodine, and perfoxine. The quantitative assessment of revascularization was carried out of the scar body zone. Each drug in 5 consecutive fields of view with the zoom 400 was calculated for a number as vessels, arteries, capillaries, veins, and sinuses. The destiny of the vascular network in groups of animals 2 weeks after the drug ending is shown on a slide. That the average number of vessels on the field of view in the control group amounted to 92 and 9 and 40 in the main group. Left ventricle dilatation was estimated by heart section. The left ventricle dilatation was calculated in the ratio of the left ventricle luminal area on the myocardial area of both ventricles. The resulting left ventricle dilatation index was calculated 3 sections in the average was delivered. The left ventricle dilation index in animal groups 2 weeks after the drug ended, as shown as a slide, was where 0 and 23 relative units on the control group and the 0 and 19 in the main group. The statistical significance in the difference between groups, both cases calculated using a novel test, had high integrity. We declare that there is no conflict of interest in this study. Thus, based on our result of our study conducted, is maybe concluded that the pyrimidine against 5-oxymethyl leads a significant increase on the density of the vascular network in the zone of border of post-partial cardiosclerosis by the 91% and privilege for the remodeling of the left ventricle in the post-infarction cardiosclerosis model in rabbits, and left ventricle dilatation index in the main group is 70.2, lower than the control group. Thank you for your attention.
Thank you, Doctor. Maybe I can get the panelists, whether you want to comment anything on this study. Alan, do you want to say anything?
Yeah, that was a very good presentation. And so on this ground, how would you take this research forward, the next stage of your research?
Bogdan Aleynik want to say that the next stage will be research in genes expression and the stimulation of neoangiogenesis.
I'm interested in the model why he selected rabbit, because in our study progress we all use the rats, and so I don't think the rabbit is a good model for the post-infarction model.
Okay, thank you very much to the first presenter. I think a very interesting paper, and probably to move on to see how it can be implemented in humans, right? Thank you very much. And I'd like to welcome my co-moderator, Dr. Pusas. Hi.
Good evening, Professor Ahmed. How are you?
I'm okay. So I'll introduce the second speaker, and probably after that you can take over to introduce the subsequent speaker.
Okay. Thank you, and apologize for my, we had a bit of a problem. Anyway, our next presenter is talking about PM, visceral adipose tissue, coronary artery calcification, and heart failure. Right. A moderated session analysis abstract. The presenter is Dr. Chun-Wei Lee. Welcome.
Good morning, ladies and gentlemen. Good evening. My name is Chun-Wei Lee, and today I would like to share a moderate-mediated model of discussing the association between visceral adipose tissue, coronary artery calcification, and heart failure. And these are epidemiology study, and the evidence is from the Jackson Heart study. First of all is the background. African American is a very special issue. We all know that according to previous literature, we know that African Americans have a different prevalence of heart disease. And we also know that heart failure is a very severe problem, like 5-year survival rate after the first time of the patient went into hospital for hospitalization, the survival rate is below 50%. And meanwhile, previous evidence also showed that excess visceral adipose tissue has a lot of adverse cardiovascular consequences, including heart failure. So these are the evidence talking about the association between the visceral adipose tissue that causes heart failure in different groups or categories. So we already know that VAT will cause heart failure, but we would like to know whether the detailed mechanism, whether it has another pathway or other mediators, including coronary artery calcification. So the study design in the population the data is from the Jackson Heart Study. You probably all already know. The Jackson Heart Study is the largest single-site community-based epidemiological investigation of the genetic factors associated with cardiovascular disease among African Americans. And this is also funded by the National Heart, Lung, Blood Institution. It's generally held in the state of Mississippi, which is southern part of America. And the Jackson metropolitan area includes 3 counties. And this is a community-based cohort. So the study result is they have a few visits, and during their second visit, those population who received the CT scan, and the CT scan will help evaluate the coronary artery calcification and the visceral adipose tissue. And of course, we exclude those patients who already has heart failure during the baseline, and those refuse for medical record. So our sample study population is 1,952. This is the general characteristic of the overall patients. And these are we separated into those patients eventually had heart failure and who don't have heart failure, their characteristic at the end. So in this diagram, we could show that on the left-hand side, the pink color is those who absent of coronary artery calcification, and the green-blue one is those who have coronary artery calcification. And you could see that those who doesn't have coronary artery calcification has a higher proportion of not developing heart failure at the end. And on the other hand, we also could see those who have lesser VAT, especially those who are lesser than the median, they won't develop heart failure eventually as well. So we try to use a model, try to explain how the mechanism or how the association between those. And we did some univariable and multivariable adjustment, and we used the Cox model. So you could see that this is our DAG, which is the conceptual framework of our study. And eventually you could see that there are some direct effects from VAT that will cause heart failure, and also some indirect effect by the pathway of coronary artery calcification. And the mediation proportion is like 5.68%. So it means that this pathway accounts for 5.68% of the reason that VAT would cause heart failure. So that means the VAT will cause heart failure directly and indirectly by the pathway of coronary artery calcification. So VAT, it could cause heart failure, and VAT could cause coronary artery calcification. And our study is trying to prove the last one. And for the reason why VAT could cause coronary artery calcification, one is that they share many traditional common risk factors, including hypertension, diabetes. And the excess VAT will have a higher insulin resistance, and this would also will cause heart failure as well. And for those VAT, they will have some paracrine effect, endocrine effect, and the VAT will also cause some low-grade inflammation activity. And these inflammation activity will further deteriorate the coronary artery calcification. Meanwhile, the adipose tissue has lipotoxicity that would from abnormal free fatty acid metabolism. So this is a diagram showing that visceral adipose tissue will cause inflammation and further causes atherosclerosis. And for the
can you wrap up, because we are, I think.
Okay. Sorry. Okay. So for the coronary artery calcification will cause heart failure. They will have also share similar risk factors, and the calcification will cause coronary atherosclerosis, will limit coronary flow. And calcification of the artery represent arterial stiffness and will cause diastolic dysfunction. And it also, the calcification of the coronary the artery also means impairment of the endothelium function. Of course, there are some limitations. First of all, according to the cohort we have, they don't have the subtypes of the heart failures. And we also rule out some patients, those have overweighted, which is more than 350 pounds, because of the CT scan cannot be performed. And the Jackson Heart study is only included those Black participant, which is the African American. So the generalizability won't be that strong. And this is an observational cohort, so they will always have some residue confounding. So the conclusion is that this study demonstrates the association between VAT, coronary artery calcification, and heart failure. And VAT have direct effects to heart failure and also indirect mediated by coronary artery calcification. So if we could do some intervention efforts to improve VAT and CAC, that could also be beneficial of preventing the development of heart failure. And further study will be needed to confirm more detail and more of the subtypes of the heart failure and the detailed mechanism. Thank you very much.
Thank you. I think it's geared for understanding disease among the African Americans. I kind of wonder whether there's any data that would suggest that these may be applicable to Asians, for example.
The next step of the study is we would like to, because this is kind of like a description of the epidemiology. So the next step is we would like to compare it, try, of course, different database or different cohort is hard to make some direct comparison, but our next step is try to see whether this association is also could be seen in the Asian population. And meanwhile, the next step is to try to find the reason, probably because of the genetic or environment or even diet or something else like that. That probably will provide more information for the further prevention of the disease.
Any panelists would like to comment? Or
Yeah, I have one more question. Thank you for your nice presentation. And you mentioned that the visceral adipose tissue cause heart failure. And why didn't you put subcutaneous adipose tissue as one of the variables when you analyze the multivariable analysis?
Thank you for the excellent question. Actually, we did the analysis before, and for one reason is that the previous literature shows that a visceral adipose tissue has a stronger effect of causing heart failure, much more than subcutaneous. But we also tried to do the analysis, and our result is similar with the previous data. So that's why we put visceral adipose tissue. Meanwhile, there are some interactions between visceral adipose tissue with subcutaneous. So probably the visceral adipose tissue will represent part of the subcutaneous adipose tissue effect. So for one reason is the previous literature, and for the second reason is the subcutaneous. The analysis isn't significant.
Thank you.
Thank you very much. We're sorry, but we're running out of time. Interesting topic. We have to keep moving. Professor Amin?
Yeah. Hello.
Would you like to introduce our next speaker?
The next speaker will be Dr. Zainab, highlighting healthcare disparities in the scientific contributions presented at TCTAP meetings. Are we paying enough attention? Sounds very interesting to me.
Thank you, Dr. Amin, for introducing me. And I really want to thank the TCTAP for giving me the opportunity to present my abstract in this prestigious meeting. Today, I'm going to talk about the highlighting of healthcare disparities in the scientific contributions presented at TCT cardiovascular therapeutic meetings. Are we paying enough attention? Speaking to you, Zainab Atiya Dakhil, an academic and interventional cardiologist at Ibn al-Bitar Cardiac Center, Baghdad, Iraq. I have nothing to disclose. Actually, cardiovascular scientific meetings play a critical role in disseminating knowledge and professional advancements, though shedding light on most crucial aspects in cardiology, and through networking and collaboration, it's important to highlight the important topics. However, there is no available data to portray the landscape of themes that were highlighted by these meetings. Considering the concerning impact of healthcare disparities globally, we sought that to investigate the reporting of healthcare disparities in interventional and non-interventional cardiology meetings. And now we are focusing on one of the most prestigious interventional cardiology meetings, which is the TCT. So we assess the reporting of healthcare disparity in TCT abstracts that were presented in the years 2018 to 2020. This is a cross-sectional analysis of TCT meeting abstracts that were published in special supplement issues in the JAC in 2018 to 2020. All the abstracts actually were secreted from both the title and then the abstract text to assess if the abstract was focusing on healthcare disparity and whether this healthcare disparity was age or gender or sex, race or ethnicity, socio-economic, geographic or circadian or seasonal disparity. If an abstract highlighted more than one healthcare disparity, then we counted each disparity separately without merging of data, because we wanted to know how often we are focusing on these disparities and which disparity is the one that's more reported and which disparity is actually we are reported less, or there is limited data about it. So the results came, and we included 2,158 abstracts, among which 121, which represented 5.6%, were addressing one or more healthcare disparities. And we can see from figure A that the types of healthcare disparity that reported in the sum of the 3 years that of the abstract that presented at the TCT meetings was actually the age disparity. And we are focusing mainly in age disparity more than 42%, while after that we are focusing on the sex or gender disparity. It's more than 39%, while the race or ethnicity ranking the third among these disparities, and it was recorded in about 11%. From figure B, we can see that the TCT 2018, we have actually about 3.8% of the abstracts reported within the focusing within the total abstracts about the healthcare disparity, and it's this percentage increasing to TCT 2020, and actually this is the number of the abstracts rather than the proportion. So we have an increase of the percentage of the abstracts among the total abstracts that focusing on healthcare disparity. So it was about more than 3.8 and then increasing to about 8% within the TCT 2020. And we can see the gender disparity is the most reported disparity within the TCT 2018, while the age disparity remains the most reported disparity within the 2019 meeting and then the TCT 2020 meetings. And actually, this is comparable to our prior work on one of the non-interventional, the clinical cardiology meetings, which is the heart failure meeting, the Heart Failure Society of America meeting. We also assessed the abstract, taking it as an example of a non-interventional cardiology meeting, and the results were actually comparable. Also, in the Heart Failure Society of America, the most common reported disparity was also age, gender, and ethnicity, but actually it was a little bit more that the abstracts focusing on disparity, because they were focusing in about 7.6% of the all abstracts reporting within the 3 years. The limitation of this study is that it lacks the generalizability of the results because we only included one interventional cardiology meeting, and we are for including most of high impact cardiology meetings to focus on this issue. So to conclude, the rate of highlighting healthcare disparity TCT abstracts was doubled from 2018 to 2020, with age disparity being the most common reported healthcare disparity, while addressing socioeconomic and geographic healthcare disparity actually continued to be limited. With an increasing interest in community health and global health coupled with increase in the population diversity, we, the researchers, scientists, cardiologists, need to focus on healthcare disparity, and we need to design interventions to overcome this concerning healthcare issue. Certainly, we will never be able to counteract this issue, which is really globally concerned, without highlighting this issue first and see how much we have healthcare disparity in our practice, whether in the diagnosis, in the management, and even in the prognosis of patients according to these variables. Specifying sessions and abstract categories for healthcare disparities in high-impactful cardiology meetings, whether clinical or interventional cardiology meetings, can really help to attract the attention of researchers and stakeholders to achieve this objective. And let's remember that, as Martin Luther King said, that is of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Thank you very much for your time and attention.
Probably not here. Okay. Maybe the other panelists, Ellen, and as well as Dr. Sun Jun Hong, any questions that you would like to ask the presenter?
Yeah, can I start, Dr. Amin?
Sure.
Yeah, Dr. Zainab, this is a great presentation. I think as the chair-elect of ACT's GARTI program, I think I'm very much in tune with this presentation of yours. In the context of even the management of STEMI, I think in our region, in the Asia-Pacific region, less than 5% of the patients have actually access or reasonable access to primary PCI. So in taking on your project going further, particularly for the TCTAP meeting, how would you, or what recommendation would you make to the organizing committee going forward based on the results of your findings?
I think, to be honest, the idea hit me first when I saw the one of the categories that was recently added to the one of the clinical cardiology meetings, which is the HFSA meeting, when it added the category of the healthcare disparity. In Iraq, about 4 years ago, more than 4 years ago, we started for the first time in Iraq the clinical audits. Never done in Iraq before. So we started the clinical audits in cardiology, and we noticed that there is disparity. Then we wanted to know why this disparity in management of patients. We saw the variables of gender and circadian and so on. So during attending, in the last 2 years, during attending meetings, we focused that there are many meetings are actually underestimating. There is underestimated all the submissions or the abstracts that are focusing on such thing, despite that we are all, whether in the social media and the high impactful cardiology journals, we are seeing that there are certain issues focusing on the healthcare disparities, and there are calls for papers and so on. For early career researchers who want to focus on work, who are usually taking their ideas and their networking and collaboration for meetings, it's important that the meetings, which is the first step usually, especially for early career researchers, it's important to highlight sessions on the disparities and so on, so that we can work on that, we can focus on that, the clinical community, the cardiology, the scientists can focus on their research on that, or at least for their subgroup analysis of the results of their trials or of their registries.
Dr. Zhang, any comments, Dr. Zhang, before we move on? I think we are running short of time.
I'm very interested in this research, but I think the HCD needs more time to observe, so it's very difficult to every time to get a very good result to can get our medical thing and to change our disease. So I think this is a so small abstract or study presented in the TCT, maybe calling the SCD this very special area to study. So I think this is not we shouldn't pay more focus on this research, but it's very difficult to get so big value study to present in every year. So I think this may be the reason. Thank you.
Thank you for the excellent presentation. Dr. Fabio, we'd like to introduce the next presenter. I think this is Aruzal.
So it's we will go to the next interesting paper. It's the effects of silver nanoparticles in isoproterenol-induced myocardial infarction. Dr. Aruzal, University of Indonesia.
Thank you very much, Dr. Amin and Dr. Fabio as a moderator for my session. So first of all, I would like to thanks to the committee that allow me to share my research to this prestigious meeting. So I'm Wawai Muli Aruzal. I'm coming from Department of Pharmacology and Therapeutics, Faculty of Medicine, University of Indonesia. So my research is the effects of silver nanoparticle in isoproterenol-induced myocardial infarction. So I would like to slideshow. Okay. So coming to the background. So as we know that mitochondrial dysfunction is the key feature of several diseases, particularly in myocardial infarction. So the cardiac mitochondrial damage can be resulted from the generation of oxidative stress. So it's still searching for the therapeutic approach to ameliorate the oxidative stress seems crucial. So we already know that significant advance in nanotechnology open new venue in mitochondrial dysfunctions therapeutic. So next, I will share our silver nanoparticle. So actually, our team member already successfully to formulate a new nanoparticle. We form a nanoparticle of silver by radiation with gamma, and then we stabilize with arginate. So in this research, we want to check whether our silver nanoparticle can be useful to protect mitochondrial dysfunction in isoproterenol-induced myocardial infarction in rats. Silver. Yeah. So this is the step how we how we form the arginate stabilized silver nanoparticle by gamma ray irradiation. So as you can see here, we have already characterized our silver nanoparticle. So the concentration of silver is about 480 ppm, and then the shape of the silver is likely spherical, and the size of the nanoparticle of silver is about 10.18 nanometer. So you can see we already checked by TEM, and the silver concentration is we check by FTES. So next, I would like to share how we induce myocardial infarction in our rat. So actually, we use the isoproterenol model. So the isoproterenol was injected at the day 13 to 14, or only 2 dose administration by subcutaneous. The dose of isoproterenol is about 80 milligram per kg body weight. So the silver nanoparticle, and then we also compare with the nanoparticle with the conventional formulation. It means silver nitrate. So the dose of silver nitrate as well as also the silver in nanoparticle formulation is 2.5 milligram. So we divided rats into 4 groups: normal group, isoproterenol group, silver conventional group and silver nanoparticle group. So at the end of the study, it means at day 50, we collect the blood and then we check the cardiac toxicity marker as well as the CKMB and then lactate dehydrogenase, and also we check the liver and kidney function. And then we also perform the antioxidative parameter, malodialdehyde, and total antioxidant capacity. And then from the heart tissue, we check the expression of BNP, brain network peptide, and then the two gene mainly very important for biogenesis of mitochondria, TFAM and PGC1 alpha. And then we also check the histopathological analysis by HE staining, and then to check the inflammation, we also perform the NF-kB and NLRP3 expression by Western blot in heart tissue. Yeah, so coming to the result of our study. So as you can see here, the isoproterenol only caused the increase of lactate dehydrogenase and also the CKMB enzyme. So interestingly, we can see that the co-treatment with silver as well as also silver nanoparticle would reduce the level of lactate dehydrogenase as well as also creatinine phosphokinase. Yeah, and then we also check the liver function. So you can see that the isoproterenol cause increase the level of ALT as well as also AST, and then we can see that both silver as well as also silver nanoparticle could reduce the liver enzyme caused by isoproterenol. Similarly, also in the renal function, that ureum and creatinine level was increased because of induction of isoproterenol, and we found that co-treatment with the silver could reduce the increased activity of the renal function. Similarly, yeah, in antioxidant parameter, so you can see that isoproterenol cause the increase of serum malodialdehyde level and also the decrease the total antioxidant capacity. So co-treatment with silver and also silver nanoparticle could ameliorate this kind of increase the oxidative stress parameter. So you can see that the silver nanoparticle has better efficacy compared with silver in conventional formulation. So coming to the expression of the TFAM, PGC1 alpha and BNP in check with RT-PCR. So the isoproterenol caused reducing the mitochondrial biogenesis TFAM and PGC1 alpha, and we can see that co-treatment with silver as well as also silver nanoparticle can increase the level of TFAM and PGC1 alpha. Next, we also check the mitochondrial. So in the last in this figure, we also perform the Western blot analysis of inflammation, NF-κB and NLRP3, and then we can see that isoproterenol increase the protein expression of NF-κB and also in NLRP3, but only in NF-κB level, silver nanoparticle would reduce the high intensity level of NF-κB caused by isoproterenol. But in NLRP3, there are no beneficial effect of silver nanoparticle as well as also nanoparticle. So this is the histopathological feature of the HA staining. So isoproterenol cause destruction of the heart tissue, and we can see that silver nanoparticle have a protective effect to to reduce the pathological change of the histopathological features. Yeah, so the conclusion or take-home message of this study that the alginate stabilized silver nanoparticle have a cardioprotective effect against mitochondrial dysregulation induced by isoproterenol. But some of the mechanism involved in silver nanoparticle need to be clarified in the further study. So thank you very much for your attention.
Thank you very much for your nice presentation. Any questions from the panel? Do we still have time for questions?
We have about 4 minutes. I think there's one presenter that did not turn up. So we have another 2 more presenters. I think we're okay with time.
Okay. So are there any questions?
I just have a simple question. Thank you for your nice presentation. And you used the silver nanoparticles. And how did you calculate the intraperitoneal dose of silver nanoparticles, which was, I remember, 2.5 milligram per kilogram? Did you do the other research to calculate that dose?
Yeah. So we, the concentration of our formulation is by ppm. So I forget how to calculate. To transfer from ppm to milligram per kg body weight. But there is some formula to convert the ppm to the milligram per kg body weight. Okay, I will describe it in the next. I think I will make the manuscript for my study. So just prepare the manuscript for this one, and then I will in the material and method I will explain how I calculate from ppm to milligram per kg body weight. Thank you very much, Dr. Sun. Because of this is the teamwork, so I'm not the one who make the silver nanoparticle. So there are someone who expert in this kind of study. So I myself is a pharmacology. So I use this kind of silver nanoparticle and I inject it to our animal model.
Professor Rahman?
Okay. If not, I think we have to move on. I think the next presenter, Dr. Fatima Aisha Kadir. This is rather interesting as well. Impact of the COVID-19 pandemic on cardiology services and catheterization volumes in the second year, a comparison of 2020 and 2021 at the Tertiary Cardiac Center in Bangladesh. Dr. Fatima, please.
Thank you very much for the introduction, and also to TCTAP for the opportunity to present our abstract. I'm an interventional cardiologist with an interest in cardiovascular health services research in lower middle income settings. So this abstract on the impact of the pandemic on cardiology services and cath lab volumes in the second year is a reflection of that interest. I have no conflicts of interest to disclose. So there's very little data from South Asia on the impact of the COVID-19 pandemic on cardiology services and indeed catheterization laboratory volumes during the second year of the pandemic, particularly considering the Delta variant of SARS-CoV-2, which was novel at the time. Now, of course, we have Omicron as well. So the Delta variant of SARS-CoV-2 had profound effects in the South Asian region during the second quarter of 2021. And we aimed to assess this impact at a tertiary cardiac center in Bangladesh. And the center I work at has referrals from all corners of the country. And we have a very high volume in terms of coronary procedures. So as for methods, data on inpatient visits, admissions, procedures, and catheterization volumes were collected from January to October 2020, which was the time of abstract submission to TCTAP. And this was compared with the same data for 2021 with data collected via hospital electronic records. We compared each corresponding month for each year, and this difference was expressed as a percentage. Then data for each quarter the third quarters of each year were compared using the student statistically significant. So in terms of the results, this is a line diagram showing the cardiology admissions. As you can see, the blue lines depict 2020 and the orange lines are for 2021. As you can see, there was a significant dip in terms, a steep dip in terms of cath lab volumes at the outset of the Delta variant, which resulted then following with a catch-up. And interestingly also to note, at the beginning of 2021, we had almost reached pre-pandemic levels in terms of cardiology admissions. So there was a significant increase in total inpatient admissions in 2021 as compared with 2020, where there was a reduction at the beginning of the pandemic. This was also true for outpatient procedures, where we had increased to the tune of 40%, 45%, similar to cardiology admissions. And of course, the decline in the second quarter, total admissions, outpatient visits, and outpatient procedures were still significantly elevated in the second quarter of last year as compared to the preceding year when the pandemic struck. As for emergency room visits, interestingly, although they increased, the increase was very small. It was only by 11% overall in 2021, which was not significantly different from the preceding year. So we can see that this still remains relatively blunted and is probably a reflection of perhaps lockdowns and patients from the peripheries not being able to make it to the emergency room visits. As for cath lab procedures, a significant increase of total cath lab volumes was observed in 2021 to about 40% as compared with 2020. But as you can see, as a reflection of the overall cardiology admissions, also cath lab procedures took a significant dip in April, which resulted in a slow catch up in May, and then getting back to near pre-Delta levels by June. As compared with the first quarter, admissions and cath lab volumes then declined, but by the third quarter, it continued to increase, is evident from the line diagram. And if we looked at specific procedures in our cath lab, all coronary angiographies, PCIs, as well as permanent pacemakers all declined in the second quarter, but overall, as you can see in the p-values at the bottom of the slide, they were all significantly higher in 2021 as compared with 2020. So there was pickup despite the fact that there was a decline in the second quarter. And compared to the second quarter of 2020, cath lab volumes were still elevated numerically in 2021, although not significant, with, as you can see, the graphical trends showing increased volumes in the third quarter. And overall, there was a significant increase in permanent pacing as well, to the tune of about more than 50% increase in 2021 as compared with 2020. So in conclusion, cardiology services and cath lab volumes had reached almost pre-pandemic levels in January and February 2021. And although admissions and cath lab volumes declined during the second quarter, coinciding with the Delta surge, they were still higher than the corresponding months in the preceding year when the pandemic first hit. This study has a few limitations, of course, given that it is single center tertiary data and may not be representatives of state hospitals in the rest of the country. However, they indicate an encouraging adaptation of the healthcare systems to care delivery during the prevailing pandemic.
Yeah, thank you. I think you are well with time. We have 3 minutes for discussion before the last presenter. Just like to know about your numbers of primary PCI. I think a lot of us, first part of the pandemic, we went for thrombolysis first, then only for PCI. Has that changed in 2021? And that is probably one of the things that we look at even at our local center.
That's a very interesting question, and you're absolutely right. I think we also got a little too comfortable thrombolizing patients after the pandemic. So that is a trend that has still stuck, particularly because we only have 2 cath labs and we cannot designate one as a dirty cath lab for unknown cases of primary PCI. So the primary PCI levels have not picked up. But we have a very, very successful pharmacoinvasive strategy where patients are thrombolized with tenecteplase and go for an angiogram within 24 hours with, I mean, I have the data, but I can't show it to you right now because but offhand, anecdotally, I can tell you that we have very successful results with pharmacoinvasive.
Okay. Any other questions from Dr. Fabio and the panelists? We have about 2 minutes.
I have a question. If your patients need to do a pulmonary PCI, so So this patient should transport to a special hospital or transport to your special cath lab to do that.
So as I mentioned, we don't have a lot of primary PCIs going on, particularly because of the fact that there is a shortage of cath labs, and we are unable to dedicate, as you can see from the volumes, we are unable to dedicate a cath lab for potentially infected COVID patients. So we have, our center used to do a lot of primary PCIs previously, but this is not so prevalent now post-pandemic, but we do a lot of pharmacoinvasives where we still have the patients do an RT-PCR, so the results come within about 5 to 6 hours, and then we are taking them to the cath lab for angiography and subsequent PCI.
Thank you.
How did your experience from 2020 and 2021 prepare you for what's happening now, for example, with the very widespread Omicron variant for COVID?
That's an interesting question, Dr. Fong. I think it's experience and also the availability of facilities, because when the pandemic first hit in 2020, A, we didn't know, and B, we didn't have the testing facilities. So now we have very rapid testing, which enables us to also take our patients to the cath lab faster. But of course, they also have to present. So during the beginning of Omicron, I think maybe about 4 weeks back, we had, again, a very steep fall. But the catch-up has been so great that over the last 2 or 3 weeks, we have about 45, 50 cases a day in 2 cath labs on some days. So it's, I think, also a matter of adaptation. The staff has adapted to take on the load that happens during the catch-up period. And I guess that's the preparation that the pandemic has taught us.
Thank you.
Thank you very much. Well presented and good questions. Dr. Pavio, would you like to introduce the last speaker?
Yeah, so we go to our last presentation, but not least. It's the next presenter is going to talk about prognostic value of fibrinogen to albumin ratio in patients with coronary artery disease and diabetes following percutaneous coronary intervention. Dr. Peizhi Wang from Fuwai Hospital, China. Dr. Fuwai.
Thank you, Mr. Moderator. And for your gracious introduction, it is my great honor to have the chance to address you on this special occasion. My name is Peizhi Wang from Fuwai Hospital, Beijing, China. The topic of my paper is prognostic value of fibrinogen to albumin ratio in patients with coronary artery disease and diabetes following percutaneous coronary intervention. First, the authors declare no conflict of interest. Inflammation plays a crucial role in coronary atherosclerosis progression. Increasing evidence has indicated that higher level of inflammatory biomarkers are associated with increased adverse cardiovascular events in patients with CAD. Recently, several publications confirmed that FVR had a closely association with the severity of coronary lesions as well as short-term prognosis in patients with CAD, and had been proved to have better sensitivity and specificity in predicting MACE than FIB and albumin alone. Inflammation is regarded as the common antecedent of atherosclerosis and diabetes. Diabetes mellitus has been demonstrated to be closely associated with increased risk of adverse events. However, few literature have investigated the relationship between the level of FVR, DM, and long-term prognosis in CAD population after PCI. Our study was conducted to evaluate the joint effect of FVR and DM on long-term MACE in CAD patients undergoing PCI. FVR was calculated by this formula. According to the optimal cutoff value of FVR for MACE prediction by R package, patients were divided into 4 groups as FVRH with DM and non-DM, FVRL with DM and non-DM. The primary endpoint was defined as a composite of the MACCE, covering all-cause mortality, cardiac mortality, non-fatal myocardial infarction, non-fatal stroke, and unplanned coronary revascularization. Overall, 5,298 patients were ultimately enrolled in the present study. Baseline characteristics of 4 subgroups were shown. Compared with patients in the FVRH and DM group, those in other 3 subgroups tend to be younger and male, with a lower proportion of comorbidities such as HP, dyslipidemia, and previous stroke. Laboratory index including FIB, FBG, HbA1c, TC-LDLC, HS-CRP, creatine, eGFR, and LVEF were significantly higher in patients with higher level of FAR combined with diabetes, while the level of HDL-C was relatively lower. Meanwhile, patients in other 3 subsets were less likely to have left main or 3-vessel disease, target lesions in RCA and LCX, and higher syntax score when compared with those in the FVRH-DM group. Kaplan-Meier analysis curves revealed the high risk of MACCES in patients with FVRH and DM compared with other groups. Log rank p-value less than 0.001. Cox analysis demonstrated that diabetic patients with higher level of FAR were associated with significantly increased risk of long-term MACCES. Furthermore, non-diabetic patients with lower level of FAR also had lower all-cause mortality and cardiac mortality risk than those in the FVRH-DM group. And according to further evaluation of subgroup analysis presented comparable interactions following MACE between 4 subsets and those covariates. All p-value for interactions were greater than 0.05. And in summary, we propose 2 discussion points. Should FAR be helpful to identify high-risk individuals in CAD populations such as diabetic patients? Could it be that FAR is rather a biomarker for general well-being rather than specific for CAD? In conclusion, in this real-world cohort study, higher level of FAR combined with DM was associated with worse 5-year outcomes among patients with CAD undergoing PCI. The level of FAR may help to identify high-risk individuals in this specific population, where more precise risk assessment should be performed. Thank you.
Thank you very much. Interesting study. 60% of the patients had ACS. If you were to follow those patients, which patients were the ones developing events on follow-up? Was it mainly the individuals with ACS? We know that these individuals do worse than the stable coronary artery disease over time, over the first year at the very least. What do you think are the plausible explanations to these findings, and what do you think may be the correlates that may allow us to better define how the fibrinogen influences outcomes?
I think maybe our findings could maybe our findings could let physicians to pay more attention of the level of FAR, and the level of FAR may help us to identify high-risk individuals, just like the diabetic patients, and more precise risk assessment should be performed in those patients.
Okay, thank you for your interesting talk. And Did you look into the duration of diabetes or the use of insulin in the fibrinogen to albumin ratio in association with coronary artery disease?
You say how many patients use insulin?
Yeah, I mean the severity of diabetes or maybe the long duration of diabetes. Does that have does that correlate with the fibrinogen to albumin ratio with coronary artery disease? I mean,
I'm sorry, we don't have this kind of data. Yeah.
okay.
May I make a comment? I think it's a very interesting study using FAR, but in the context of stable CAD and long-term outcomes, perhaps a little bit challenging, given that some of the patients are taking disease-modifying therapy after the admission, for example, like in acute coronary syndrome. So a single one-off reading to predict long-term events in a mixed population could be very tricky. Nonetheless, your findings are very interesting. In the 4 groups, LDL levels are approximately similar, but the hsCRP levels are higher in those patients with diabetic population. Perhaps you can recalibrate your study to look at an acute population and whether these are the ones that have an impact on short-term outcomes. So I think in your study, going forward, FUY has a large volume of PCI, and like to look at how would you move at the next stage of this study? What would your plan going forward, given you have this information?
Okay, thank you for your valuable comments. Just like you said, we may think to compare the prognostic value of hsCRP and FAR, and we want to see which one is better in the prognostic value of long-term prognosis. Yeah.
Well, if no other questions, then I think we're right on time. Professor Amin?
I would like to thank Dr. Fabio Andres Posses as my co-moderator, Dr. Alan Fong, Dr. Sun Jun Hong, and Dr. Windu Zhang, and also all the presenters for their interesting abstracts and presentation. Lastly but not least, I think we'd like to thank TCTAP 2022 for having us in this session. Anything else, Dr. Posses, that you would like to add on before we conclude?
Thank you for having us over and participating in your meeting. Great presentations.
Thank you.
So thank you very much. Goodbye.
Thank you. Bye-bye.
Bye.